welcome to our 13th lecture covering schizophrenia spectrum and other types of psychotic disorders. So this information dovetails nicely with chapter 13 of your textbook. We're going to answer a few key questions here. We're going to talk about how do we define schizophrenia and what is it? What are those clinical features that we associate with schizophrenia, and what are some related disorders that are covered in the same chapter of the DSM-5? We're going to talk about the different types of symptoms within schizophrenia, so things like what we call positive, negative, and disorganized symptoms. We're going to talk a little bit about how prevalent schizophrenia is, what the likely etiology or causes of this disease and related diseases are, and then what treatments exist to help people who are suffering from schizophrenia. One of the things that you're going to sort of hear consistently in the clinical psychology field is a reference to SMI, or serious mental illness. There's no technical definition for SMI within the DSM-5, but within my field you'll often hear SMI used to describe schizophrenia, bipolar 1 disorder of a severity that requires hospitalization for manic phases. So, really significant degrees of impairment in functioning associated with these mental health diagnoses. A lot of times what designates something as serious mental illness is that it does, at least intermittently, require some hospitalization to stabilize the patient in terms of symptoms, and often requires medication as a frontline treatment to manage those symptoms. So, broadly, we can define schizophrenia as a broad spectrum of cognitive and emotional dysfunction, which includes psychosis. And so I want to make sure that that term is clear. When you hear someone refer to someone being psychotic or to the term psychosis, what you're essentially talking about is one of two things. You're talking about hallucinations, which we'll talk about in detail as we go through, as well as delusions, which are irrational, firmly held beliefs. These two things fall under the umbrella of psychosis. So if we say a patient is psychotic or is experiencing psychotic symptoms, what that implies is that they are either hallucinating and or displaying evidence of delusions. There is also a broader, more global impairment of functioning related to schizophrenia that includes things like disorganized speech and behavior and inappropriate emotional responses to various stimuli. So schizophrenia has been with us as human beings throughout our evolutionary history. It has been studied extensively and is one of the sort of earliest things to be identified by clinicians and researchers. If you remember Emil Kraepelin, we talked about him in one of the earlier chapters of the book. He's one of the original developers of a taxonomy for various types of psychological disorders. And he used the term dementia praecox to describe schizophrenia syndrome. Now, that can be a very misleading term because we now have a very different connotation for the term dementia, which we're going to talk about soon. But he did identify this syndrome under that name. And he also broke it down into some early subtypes, catatonics, hebephrenia, and paranoia. We're going to talk about all of these former types that were included even as recently as the most recent edition of the DSM prior to DSM-5 in DSM-4 TR, which stands for text revision. That was the version that came out before the current DSM-5. There was still subtypes of schizophrenia designated. We've since gotten rid of that, but we'll talk about that in a subsequent slide. Eugene Bleuler, who is sort of one of the unsung heroes of early psychology and psychiatry, introduced the term schizophrenia. And I think there's a misconception, again, talking about connotations versus actual denotation or definitions of the word. The same way that someone will describe themselves as bipolar because they have labile mood or because they're flighty in some way, people used to describe themselves as schizophrenic in meaning that they had a quote-unquote split personality, which of course now we've discussed is more consistent with what we call dissociative identity disorder, what's formerly called multiple personality. So there's a lot of connotations for the term schizophrenia that are not necessarily accurate, as is the case for things like bipolar or someone saying I'm OCD, right, when they don't literally mean that diagnosis. So but Eugene Bleuler was the one who introduced that term. He meant that as a description of how the person's identity or sense of self was split in terms of their desire to function in normality, and then these sort of disorganized symptoms that were manifesting He also identified different variants that were all included within a spectrum. So even in these early phases of our understanding of schizophrenia, we already have the idea of it being along a continuum with varying degrees of severity that impair people's functioning. And we'll talk a little bit about some of the other psychotic disorders that can capture these less severe versions of what we might think of as full-blown schizophrenia. So there are a lot, as I said, a lot of writings, a lot of early research and writing about schizophrenia. Many of the ideas that came from Kreplin and Bleuler are still with us. They were very effective at defining sort of the onset and the course of schizophrenia. It is a chronic condition. And they also were important in defining that concept of psychosis or psychotic behavior. So traditionally, when we talk about psychosis today in psychology, we're talking about hallucinations and delusions. There was also a former umbrella term, psychosis, that included things like the unusual behaviors that sometimes come along with schizophrenia, inappropriate emotionality, strange or stereotyped behaviors, that kind of thing. But we'll talk about that as we go further when we break down every symptom associated with the diagnosis. So this is one way to make sense of the symptoms within schizophrenia, which is to break them down into this tripartite system, these three different headings. And it can be a little confusing because of the terminology. So I'm going to walk through these and then we'll go through each individually in a slide. But we refer to the positive, negative, and disorganized symptoms of schizophrenia. I think those terms can be misleading because positive and negative have some pretty normal connotations in language. We assume positive means good or beneficial, and negative often means bad or detrimental somehow. What this terminology is getting at in schizophrenia is the presence of something that is excessive or amplified compared to a quote-unquote normal person. The negative symptom is the absence or a deficit of what we consider normal functioning to some degree. And disorganized symptoms is really about erratic behaviors, usually related to speech, motor behavior, and emotional reaction. So when we talk about the positive symptoms or positive signs of schizophrenia, we are generally referring to psychosis. So those delusions and hallucinations that are so sort of characteristic of schizophrenia. So by positive, what we mean is that that person has them in excess to a average person without schizophrenia. So for example, it's normal to be imaginative. It's normal to have some mild degrees of paranoia at times. But in the case of schizophrenia, it is taken to an extreme. So there might be moments where you have a belief that you're special, but not in some completely irrational or in way that's just disconnected from reality. We're getting back to this theme again over and over of symptoms existing along a continuum, and that we cross some essentially imaginary threshold and you suddenly have a disorder. We now understand from talking in this class that the criteria set down in the DSM are really just an agreement amongst researchers and scientists within the field. It's based on clinical evidence, it's based on a lot of hard research, but ultimately we make a decision that this is a threshold that now counts as the diagnosis, so to speak. So what you've got going on here is this idea of symptoms along a continuum that are in excess of a average person. On the flip side of that, we have the negative symptoms, which are really the absence of normal functioning. So this is the person that presents with schizophrenia often does a poor job of caring for themselves, of meeting basic standards and necessary responsibilities. Avolition is a term that involves the inability to start or complete behavior, a lack of motivation. Alogia, social withdrawal. These are all symptoms we're going to discuss in detail as we go on. And then the disorganized symptoms, like I said, are really more erratic or strange or eccentric behaviors that are commonly associated with schizophrenia. So in the case of all of these, many people have normal manifestations of these symptoms, but when you reach extreme levels, you start to associate them with this diagnosis or related diagnoses. So again, let's talk about the positive symptom cluster. As I said, it can be a little misleading with the terminology. It does not mean good, it means additional. It means experiences that are added on top of normal functioning or magnifications of normal processes. So essentially when we talk about positive symptoms or psychosis, we're referring to as delusions and hallucinations. And we'll talk about each of these in some detail. So Delusions referred to historically as the basic features of madness, right? These are gross misrepresentations of reality. There are many examples. The most common are delusions of grandeur and delusions of persecution. Excuse me. So delusions of grandeur, I'm sure you've heard the term that someone is being grandiose, right? This is the belief in one's own specialness, that you have an extreme example of something unique about you. It may be indicative of some special knowledge or power. A person with schizophrenia in the midst of psychosis might believe that they are the reincarnation of an important deceased historical figure. This is the old cliche and kind of negative stereotype about people with schizophrenia, that they believe they are Napoleon, for example, right? This is kind of if you go watch Looney Tunes cartoons, you're going to see a reference to this, which at the time was considered an appropriate representation. Of course, now we might find it a little bit offensive. But the idea is that there is something unique and special, and many people would draw from their historical knowledge to associate themselves with these figures. My mother, as a little anecdote, my mother was a psychiatric nurse at the Austin State Hospital in Texas in the late 60s. And she always tells this joke about, not a joke, she tells this anecdote, this story about how there was a young man who very much fit the sort of Western representation of Jesus, tall, thin, blonde hair, blue eyes, sort of classic early Catholicism representation of Jesus. And he was preaching in one of the fountains on the University of Texas campus when he was arrested by the police for trespassing, and was taken into custody at the Austin State Hospital because he insisted that he was in fact Jesus. So that is sort of classic delusion of grandeur par excellence. She also remembers distinctly that a lot of the Latina Hispanic nurses that she worked with who were Catholic told her they did not want to help administer ECT to this individual just in case, which I thought was quite funny. But the idea is that believing you are someone important from history is a common delusion of grandeur. It can be less specific. It can be that you are as I said, the holder of special knowledge. You may be able to speak to God or some other power. You may possess unrecognized genius, is another very common delusion of grandeur. Delusions of persecution are often referred to as paranoia. So this idea that the government or someone is trying to kill me is a very common example of a delusion of persecution. There are several other types of delusions that are common in schizophrenia. And let me just stop for a moment and define what I mean when I use the term delusion. This is basically a firmly held belief which is inconsistent with evidence or logic. So the person, in the absence of a rational justification for this belief, nevertheless holds to it very firmly and believes it very strongly. And that's really what distinguishes a delusion from, say, an eccentric or unusual belief, is that there is no rational evidence to support these beliefs at all. Delusions of reference, also sometimes called ideas of reference, is the idea that someone is communicating with you in a special fashion, or that things refer to you specifically, even though there's no indication of that. So there might be secret messages being conveyed directly to you through the pages of the New York Times, or Jimmy Fallon is talking to me during the monologue on the Tonight Show. There's something called somatic delusions, which usually involve irrational beliefs about one's body. So the idea that my internal organs are being eaten away by insects, or there is microscopic alien technology within me which is manipulating my behavior. Delusions of thought broadcasting are also quite common in schizophrenia. This idea that I'm able to send messages, through telepathy, that kind of thing. Some people, and sometimes this is done, as far as the person's delusion is concerned, unintentionally. I can't stop broadcasting my thoughts, or it may be that I'm intentionally able to send information to important people in a variety of ways. And then there's sort of the classic stereotype we think of, which is delusions of thought withdrawal. This is what's now become kind of an idiomatic thing about tinfoil hats, right? This is the classic example of the idea of an individual lining their hat with tinfoil to prevent the government from reading their thoughts. So this idea of trying to contain thoughts that are otherwise going to be broadcast or somehow captured by others against one's will. So these are all sort of examples of common delusions. And as I said, grandeur and persecution or paranoia are the most common types that you're going to see. So let's define hallucinations in the context of schizophrenia. So we know that hallucinations can occur outside of schizophrenia. They can be the result of intoxication with certain types of drugs like LSD or psilocybin. Um, the other aspect is essentially, though, and they can also occur in the context of a delirium or an infection. Certainly they can occur in the context of dementias. But when we talk about them in schizophrenia, what we're essentially talking about is an experience of your senses that doesn't have any input from the environment. Essentially, hearing voices that are not audible. There is no movement of the air to create the sound, right? There's no actual stimulus. Um, or seeing things that are not actually present. And we're going to distinguish this from a concept called illusions, which is when you misinterpret real stimuli, and sort of turn them into something else. And I see this very commonly in dementia in my patients. So there might be a hat rack in the room that has a winter coat on it. And in low light, the individual with dementia might misinterpret that as someone standing in the corner of the room. But there is a real stimulus that they are interpreting. They're just misinterpreting or filling in some blanks. A hallucination generally is in the absence of any stimulus whatsoever. Now, there is a common misconception about schizophrenia that it involves a lot of visual hallucinations. The most common hallucination is in fact auditory. The vast majority of people with schizophrenia that report hallucinations are hearing voices. But the idea is that visual hallucinations are possible in all other senses. So tasting something that's not present in your mouth when not eating, having skin sensations or tactile hallucinations when not being touched. I distinctly remember that when I was a psychology tech, when I worked briefly in an inpatient facility before going to graduate school, there was a very, very sad case of a young man who also had some developmental delay and some neurodevelopmental problems, but he was about 14, 15 years old and was brought to our unit by the police and with his family's support, wearing only a gown from the hospital because he was having very powerful hallucinations that there were snakes crawling on his skin. And this was his first psychotic break. This was probably the beginning of his unfortunate struggle with schizophrenia. And what he was experiencing was he was seeing, hearing, and feeling snakes on his skin. He would constantly, in groups, he would have that, he would refuse to wear normal clothes. He would only wear the gown because it made him feel better. He was able to essentially continually check himself for these things. He would stick his face down into the gown so he could look at his body and make sure there were not snakes on him. But I distinctly remember that was the first time that I'd been exposed to someone reporting tactile hallucinations. He would actually feel these snakes on his skin as part of the hallucination process. So, as you can imagine, hallucinations can be very disturbing to individuals with schizophrenia, especially when they are not able to distinguish them from reality, especially in the early stages of the illness. Some people with schizophrenia who have been living with it for years can distinguish their hallucinations from reality, making them less distressing, but obviously still upsetting. What makes this unique, obviously, in schizophrenia and in other situations where a person is hallucinating without knowledge as to why, is they are attributing the sources to outside themselves. So when a person with schizophrenia is having auditory hallucinations, for example, they don't necessarily believe that this is simply a voice inside my head. This is a production of some misfire of certain dopaminergic systems in my brain. What they think is there actually are people talking about me. I am hearing voices commenting. They may hear voices talking to them. They may be overhearing a conversation amongst other people. And then in some cases, you have what are called command auditory hallucinations, and that is when the voice is telling them to do something. We often associate command hallucinations with being with more severe cases of schizophrenia, especially if those commands are asking the person to harm themselves or harm someone else. One small issue that I won't belabor too much is that there is a common misconception that people with schizophrenia are inherently dangerous, and this is actually not true. They are less likely to engage in physical violence than individuals without schizophrenia. But in the midst of a psychotic episode, especially an extreme one that's very frightening or distressing, the person may lash out or may relent and respond to those command hallucinations as a way of trying to quiet those voices to reduce their distress. But generally speaking, we don't need to be concerned that people with schizophrenia are necessarily violent. I think that's a common misconception when in fact the data says that they're actually not as violent as their non-schizophrenic peers. as I said, most common is auditory. If you've ever seen the film A Beautiful Mind, which is in some ways a good representation of schizophrenia, but in others not so much. The real physicist that movie is based upon actually never experienced anything but auditory hallucinations. For the purposes of the film, they created this entire visual world that he was engaging with. I don't want to spoil the film if you haven't seen it, but essentially, I believe what they were doing was they were trying to represent his delusions in visual form, but it was somewhat misleading for the general public about how schizophrenia works. Most commonly, they do experience auditory hallucinations compared to visual. So there are some interesting studies that have looked at how the brain is functioning in people with schizophrenia. SPECT studies, which is an offshoot of a PET scan, has found that parts of the brain most active during auditory hallucinations are what's called Broca's area in the brain. And Broca's area in the brain is associated with speech production, not comprehension. So what you're essentially seeing is that part of the brain that's lighting up during a SPECT study while the person is experiencing auditory hallucinations is the brain is producing that speech, not receiving it, not comprehending it. It is a separate part of our brain that's involved in language comprehension as opposed to production. So what we're getting at then with this study, what the insight that comes from this type of research is that auditory hallucinations may be less of an experience of hearing things that aren't there and more an experience of listening to one's own thoughts or self-generated voices without being able to differentiate these voices and external auditory input. So many of us, especially as we pass the age of 4 or 5 and we established mastery of language and we start to think in terms of language, have internal monologues or internal dialogues, if you will. But the idea being that we are talking to ourselves internally, not out loud. Some of us talk to ourselves out loud when we're working. I certainly do that when I'm working on projects sometimes. But the idea is that the individual with schizophrenia may be having difficulty distinguishing what's essentially an internal voice, an internal function of their brain, from an outside source. So this is just a figure from your book 13.1 of some major areas of functioning in the cerebral cortex. Unfortunately, it's got cut off a little bit in the presentation, but the idea is that Broca's area, which is lighting up here in blue, I believe, is one of the areas associated with auditory hallucinations, speech production, not comprehension. So let's move on and talk a little bit about the negative symptom clusters. So remember, negative symptom does not refer to necessarily bad. What they're really referring to is the absence or the insufficiency of quote unquote normal behavior, a deviation from the norm by the absence of these functions that most people are able to engage with. So there's a spectrum of negative symptoms, avolition, which is synonymous with the term apathy. So difficulty initiating behaviors and persisting in following through. So you might think of this as a lack of motivation or difficulty really initiating an important responsibility. Alogia is a term for the relative absence of speech. Some people with schizophrenia are largely mute, not biologically so, but selectively so. They may speak in very short clipped terms or simple one-word answers. So there may be just this dearth of speech, this absence of speech in their presentation. Anhedonia is a term you should recognize from our discussion of depression, but it's a lack of pleasure, a lack of engaging in pleasurable activities, or when you do engage in behaviors that were previously pleasurable or are generally regarded to be pleasurable, the person's not deriving any pleasure from them. So this can manifest as indifference or just disregard for things and not really engaging in any sort of quality of life or any things that are enjoyable. Another term associated with negative symptom clusters is affective flattening. You may, if you come across someone's case report with schizophrenia, you may see the person has a flat affect. Now, if you remember our discussion in depression, we talked about mood versus affect. Mood is the emotional state, how the person feels, what their subjective self-report of their mood is. Your affect is how you present that mood, how it comes out through your body language, your facial expressions, your speech, all those things that are manifest and are visible or discernible to other people. So a person with schizophrenia will sometimes have what's called a flat affect, meaning there's very little expression of emotion. The person just seems kind of absent, or not catatonic, which we'll talk about in a moment, but just blank, blunted facial expression that doesn't seem to respond to stimuli very well. Often poor eye contact, poor engagement visually with people in terms of their facial expression. The person might have, general low energy, very lethargic, sleep more than normal. One of the major manifestations that we see with the negative symptom cluster that gets people identified as needing treatment, even before they've had that first psychotic break and the positive symptoms have emerged, is self-neglect. People with schizophrenia will sometimes neglect to bathe, to groom themselves, to dress appropriately, just kind of, failing to meet those minimum activities of daily living that we all need for hygiene and engaging in the world. There's also a lot of social isolation associated with schizophrenia. The person may spend most of their day alone or only with close family, have very few friends, or have great difficulty making friends. Again, this is part of this idea that the person is not engaging with the world in an appropriate fashion. I think that a lot of times we forget about the negative symptoms as being so significant because we're focused on the, let's face it, more kind of interesting psychotic positive symptoms, right? The hallucinations and the delusions. The negative symptoms are often present before the positive symptoms emerge. We'll talk about this in terms of the course of schizophrenia. But this is really where people fail to engage in life, and they can often, fail to meet minimum standards for what we expect out of normal social behavior. And as a result, people with schizophrenia can often be marginalized, forgotten, kind of pushed to the edges of society as a result, because they are not good at engaging socially. They don't read cues very well. It's part of the disorganized symptoms we'll talk about too. And also this idea that they are not able to read those cues in a way that allows them to respond appropriately. So the affective flattening is part of that too. You might tell the person something very sad or very happy, and they have no real emotional response to that. They don't meet you where you are. They don't do a lot of mirroring. So negative symptoms tend to be stable over time, whereas psychosis tends to fluctuate, comes and goes. The more intense the negative symptoms, the poorer the prognosis for an individual. They tend to be more prominent after schizophrenia has persisted for several years, but you do also see examples of people who have the negative symptoms before they emerge with any of the psychosis. And so we know, as we talk about in a moment, schizophrenia emerges. Often it's identified by that first psychotic break, which can frequently require someone to be hospitalized, medicated, things like that. But the negative symptoms may be more present, and they may be warning indicators of what's to come when the person sort of reaches the typical age where schizophrenia manifests in terms of psychosis. So the third cluster of symptoms we're going to talk about is the disorganized symptoms. And this is really identified with abnormal speech, behavior, and emotion. So abnormality, deviations from the norm, significant outlier deviations from the norm in those domains. So disorganized speech is something, if you've ever talked to someone with schizophrenia, you may have picked up on some of these things. There's something called cognitive slippage, which is illogical or incoherent speech. It doesn't really seem to make sense. You can't follow the person's line of reasoning from point A to point B to point C. There's something called tangentiality. A less extreme version of this is called circumstantiality in speech, but tangential speech is where the person is just sort of going off on these tangents where there doesn't seem to be a real connection. And this is also associated with what's called loose associations, where you're having a conversation with someone and it just goes off in unrelated directions. And examples of this are you certainly will experience if you work with people with schizophrenia. But they may notice something about your shirt or about your hair or about some simple word that you say and latch onto that and go off in a direction that was not really indicated by the theme of the conversation, but they sort of connected to, and it can often sort of jump all over the place and be very difficult to follow for someone who's engaging with this individual, which again only serves to isolate and alienate these people in normal everyday life, because people that interact with them are confused by what they're saying and are not really able to meet them on the level they're at. So as I said, disorganized speech and thought and speech are also a factor of this. I referenced this a little bit, but loosening of associations. So, excuse me. If you think about the concept of free association as a therapeutic technique, going back to Freud, where a patient would be asked to just free associate, just talk about anything that comes into your mind and make connections in a very free way, and don't worry about things making sense in terms of connection. Well, essentially, people with schizophrenia are sometimes doing this inadvertently. So they're having this tangential speech. It's leading to these bizarre connections between concepts, excessive concreteness. The person may have a really difficult time understanding analogies, abstract concepts, or idioms in language. They may just be sort of taking things only at face value and not be able to understand things. So if you talk about, if you use certain phrases, especially English is full of these phrases, all languages are, but English in particular has a lot of them, which makes it sometimes hard for people who are learning English to understand. But whenever we use idiomatic language, what happens is the person might just take it at face value and not understand the reference and be very concrete in that fashion. Neologisms is making up new words. So the person might create words to describe things that don't exist in normal vocabulary. They may engage in what's called word salad, which is where the person is just spouting off random words that don't seem to have any connection to themselves. It can be extremely confusing. In my previous textbook that I used for this class, for those of you that are familiar with the Athens, Georgia band REM, they have a song called It's the End of the World as We Know It and I Feel Fine. And the lyrics to that song that Michael Stipe wrote are very much an example of kind of word salad free association. The song begins with, "That's great. It starts with an earthquake, birds and snakes and aeroplanes. Lenny Bruce is not afraid." All right, these are unrelated concepts. Now, of course, Michael Stipe is taking artistic license and utilizing this technique very much the same way that beat poets like Jack Kerouac did. But in the case of a person with schizophrenia, this is unintentional, and it can be very confusing to the individual who's speaking with them because they can make no sense of it. The other disorganized aspect I want to talk about is disorganized affect or emotions. As I said, some people with schizophrenia are very flat in their affect, but others might display what's called inappropriate affect. Laughing or crying at inappropriate times. You might tell the person that someone they know has passed away and they might start smiling and laughing. You might tell them about a simple thing that happened at work that was just kind of inconsequential and they might start crying or get very upset about it. And what we think is going on is that people with schizophrenia are, in terms of their disorganization in thought, they are not picking up on social cues. They are not interpreting or understanding what's an appropriate emotional response. And in this sense, what you're getting at is the disconnect, the social impairment in functioning that's present in schizophrenia, which is also quite similar to what we see in autism spectrum disorders that we'll talk about in the next chapter. So like the person might be in a group setting and someone's talking about something sad, they might start to giggle or laugh, which of course can lead to a lot of conflict, especially if the other person does not understand that this is just a manifestation of their illness. So, as I said, disorganized affect, inappropriate emotional behavior. There are also a variety of unusual disorganized behaviors that are associated with schizophrenia. One of them is catatonia, or being completely flat and disconnected, not making any eye contact, appearing almost to be in a coma or just to be absent is one symptom we associate with that. It can be considered catatonia. If it's the only symptom, is sometimes regarded as a psychotic spectrum disorder we're going to talk about. But if it occurs in the presence of schizophrenia, the larger syndrome, then we refer to it as a symptom of schizophrenia. So catatonia, it captures more than just being absent, but that is one of the ways we typically think of it. But there are other disorganized motor disturbances we associate. So stupor and motor immobility is what we typically think of when we think of catatonia. So this is the idea of a person who just seems to be absent, staring off into space, doesn't respond to stimuli. Person might have what's called waxy flexibility, whereas if you move their arm and you let go of it, it will stay there. They won't correct or settle back to a resting position. Or they may appear to be frozen in a motor sense, so like the person's limbs may be held, or head may be held in an awkward position, and they seem uninterested or unable to move it, and that's called cataplexy. Hyperactivity is another sometimes manifestation of schizophrenia. I've seen this a lot in inpatient settings when I worked as an intern and as a tech. People who are just incredibly restless and hyperactive, but with no apparent purpose, walking up and down the hall of a unit, for example. And it's not really influenced by external stimuli. The person is just having this boundless energy that they're trying to vent in a non-directed way. Mutism or marked negativism, this sort of just absence of engaging or speaking or making eye contact. There may be peculiar behaviors such as physical posturing, holding strange positions, or ways of moving our body through space that might seem really eccentric or odd. And then some of the speech manifestations are what calls echopraxia and echolalia. This is basically the idea of, echopraxia is copying someone's physical movements. It may be done unintentionally or inadvertently. Echolalia is echoing back certain key words from what someone is saying to you. So you might talk to the person and be trying to explain to them that it's time for their medication. They might say, yes, medication, medication, got to take the medication, sort of fixating and repeating phrases that they're hearing from you. So this is sort of a common manifestation of disorganized functioning in speech and motor activity. So previously, there were subtypes of schizophrenia detailed in the other versions of the DSM that came before the DSM-5. And that was really based on the content of the psychosis. So for example, paranoid type, catatonic type, residual type, disorganized type. But in DSM-5, that's no longer there. It's really considered more along a spectrum and a more global manifestation of these, because really what happened was limited diagnostic stability, reliability, and validity was discovered through research. Essentially, these subtypes did not really delineate things that we think actually exist in terms of the manifestations of the illness, of the disorder. But they are sometimes helpful, and they're sometimes still used as sort of a shorthand amongst professionals to sort of understand what am I expecting when I interact with this patient when I first meet them, for example. So paranoid, catatonic, and residual, which is sort of minor symptoms persisting after a past psychotic episode. There was the disorganized type, which is someone who really was focused more on those presentations of disorganized thinking, affect, motor ability, speech. And there was called undifferentiated, which was sort of a catch-all for people that did not fit one of these characteristics more strongly than others. There are some other psychotic disorders in the DSM-5. Schizophreniform disorder, which is, I know, a mouthful. Schizophreniform disorder is, in many cases, a less severe version of schizophrenia. It tends to be, as opposed to the chronic course that we generally associate with schizophrenia. Schizophrenia is not an illness that goes away in many people, and in virtually all people. It can be treated and managed with medication and other forms of intervention. But ultimately, if you have schizophrenia, then you're going to have schizophrenia going forward. Schizophreniform disorder is really more of an acute manifestation of similar symptoms. So it tends to last between 1 to 6 months. If it's greater than 6 months, we start referring to it as schizophrenia. It is associated with relatively good functioning, which differentiates it again from traditional understanding of schizophrenia. Most patients who are diagnosed with schizophreniform disorder, who go through this acute episode of these symptoms will resume a normal life. It's extremely rare. Lifetime prevalence is about 0.2%. So it's not something you see very often, but it is a sort of acute, shorter term, less chronic version of schizophrenia with much better prognosis and much better general functioning. Schizoaffective disorder, I think, is one of the most confusing disorders for students in this type of class. It is, in many ways, if you think back to our discussion of anxiety and depression disorders, there's been a push within the DSM committees to have a mixed anxiety depressive disorder diagnosis, which has not been supported by the research and doesn't exist yet in the DSM-5, may not ever be, I think it's been listed as a tentative diagnosis like the last 3 versions of the DSM, going back to DSM-4. But essentially, schizoaffective disorder is where you have some symptoms of schizophrenia and some very prominent symptoms of a major mood episode, depressive or manic. This is where it can get quite confusing, I think, is that basically what you have is a combined mood and psychotic disorder. In order to meet this diagnosis, there are a few rule outs you have to qualify for. So, for example, the psychotic symptoms must also occur outside of the mood disturbance. If you remember from these previous chapters, there can be psychotic symptoms in the context of both depression and mania. People who are extremely severely depressed will sometimes experience auditory and even rarer, sometimes visual hallucinations. Um, People who are manic will occasionally experience hallucinations. They certainly experience delusions in some cases. So these psychotic symptoms, when they occur in the absence of being manic or being depressed, we start to consider schizoaffective disorder as an appropriate diagnosis. The prognosis is very similar for people with schizophrenia. It tends to be a chronic and pretty significant impairment in functioning. And as I said, they do not tend to get better on their own. They often require treatment the same way that people with schizophrenia do. Delusional disorder is a diagnosis within this chapter, which is really a manifestation of the delusions we associate with schizophrenia that meet that criteria of being irrational, firmly held beliefs that are inconsistent with reality, but there are no other positive or negative symptoms of schizophrenia present. So if a person presents with solely a delusional belief system and that's it, then we will consider this as a more accurate diagnosis rather than schizophrenia. They will fail to meet the full diagnostic criteria for schizophrenia. So no positive, no negative symptoms outside of the delusions being the only positive symptom present. Erotomanic delusions are one example. This is sort of the position that someone else is in love with you or attracted to you, often someone in power like your boss or a celebrity. We frequently see this type of delusion associated with stalkers, people who are stalking celebrities or powerful people because they're convinced they have an emotional or connection between them, that this person loves them. They can certainly be grandiose. They can be delusions of jealousy, persecutory or paranoid delusions, or somatic delusions. Like, for example, one example from the research is someone who walks in a very odd, very careful, ginger way, and you ask them what's wrong, and they say, well, my bones are made of glass. I have a condition where my bones are made of glass, and if I don't walk this way, then my bones will break. Obviously, in the absence of any real medical condition that can cause similar symptoms. There is a brittle bone syndrome that's an actual illness. But what you see in delusional disorder is someone who might have that type of somatic delusion. The prognosis for delusional disorder is better than it is for schizophrenia, but it often does involve, significant treatment, usually with medications, to resolve that, and also to try and address underlying features of potentially other comorbid mood disorders as well. Delusional disorder is quite rare, 26 to 60 individuals per 100,000, so extremely low prevalence rate. It tends to have a later age of onset than schizophrenia, so we're talking in middle age, 35 to 55. It is somewhat more common in females. About 55% of patients who present with this disorder are female. So it has some different manifestations and different onset characteristics than schizophrenia, which is one of the reasons why it's differentiated as a separate disorder. Catatonia, as we mentioned before, is considered a symptom of schizophrenia, but it can also be sort of like delusional disorder. If it's the only symptom manifesting and you do not meet the other criteria for schizophrenia, yet it's still causing distress or impairment in functioning, then you will consider a diagnosis of catatonic or catatonia. Catatonic disorder, catatonia, are synonymous. Unusual motor responses, particularly that immobility or extreme agitation and restlessness, sometimes just odd eccentric mannerisms. It tends to be very severe and quite rare. It may be present in a psychotic disorder, as I said, or diagnosed alone. Can have things present like stupor, which is sort of that sort of absent lethargy. Person seems disengaged from reality. Mutism, maintaining the same pose for hours, that cataplexy. Opposition or lack of response to instructions, so you can't tell the person to put their arm down or to pick up their plate or the fork and eat their meal. They don't respond to that very well. You might see repetitive, what they call stereotyped, meaningless motor behaviors, so kind of going through these same, they almost appear to look like tics to people from the outside, though they're not the same as tics are, which are more neurological in nature. And then there's that echopraxia and echolalia of catatonia, where the person is mimicking others' speech or movement in some way. They might be mirroring their body position, or they might be repeating back key phrases from what's being said to them. And then, as is always the case in the DSM, we often have a catch-all category, so psychotic disorder due to other causes. As I mentioned, people can experience psychosis in the presence of a lot of other things going on. In my geriatric practice, when a older individual develops a urinary tract infection or a UTI, it's quite common for that to cause what's called a delirium, an acute period of altered mental status that usually gets better when you treat the underlying infection with antibiotics. But the person might become psychotic. They might develop, delusional paranoid beliefs. They might start having hallucinations. In fact, it's quite common to have hallucinations, especially visual hallucinations, in the context of a delirium. So psychosis can occur as the result of medical conditions like those, some medications and drugs, obviously, substance use. So knowing the causes is really important for how we treat them. So you need to address the underlying cause as opposed to perhaps the same medications you would give someone to treat schizophrenia. So if it is a UTI, you need to give the person or some other type of infection that's become systemic and is causing altered mental status. The mainline treatment then is to find an antibiotic that particular infection is receptive to and to treat it in that fashion. What you'll find is by treating the underlying infection, the psychosis goes away. And there are plenty of medical conditions that can cause this, including various forms of dementia and deliriums. There is a different, so this can be a little confusing because it's basically an even less chronic version of schizophreniform disorder, but it's called brief psychotic disorder. This is where you have some positive symptoms or disorganized symptoms of schizophrenia, so hallucinations or delusions, aka psychosis, or some of the more disorganized symptoms, but it lasts less than 1 month. So this is how you capture someone who schizophreniform disorder is 1 month to 6 months. Schizophrenia is 6 months or greater. Less than a month, we use the term brief psychotic disorder. So it's the briefest duration of all these potential diagnoses. It is typically precipitated by an extreme experience of stress or trauma. Some people who are in very competitive jobs or college programs might have a brief psychotic episode that resolves when the stress is reduced or the person receives treatment of some kind. People who have been through assault or through violence or natural disasters may have brief periods of psychosis as a result. So it can be an immediate response to trauma as well. A new condition identified in the DSM as needing more studies, so this is not a full-blown diagnosis yet, is called attenuated psychosis syndrome. This is basically the idea of individuals who are at high risk for developing schizophrenia or beginning to show signs of schizophrenia. It is essentially an interim diagnosis that might be helpful in early identification of schizophrenia before the person has had a full psychotic break, for example. The psychotic break is really the first emergence of positive symptoms, and it typically occurs in individuals in early adulthood. And we'll talk about this in a subsequent slide. But we refer to that as a psychotic break, which is the first time the person experiences delusions or hallucinations. Attenuated psychosis syndrome is really a way of trying to recognize people who may have some of those negative or even disorganized symptoms present already, and you want to focus attention on these individuals because they may benefit from some early intervention. We know that the psychotic break tends to occur under times of great stress. It is sort of an example of the diathesis stress model writ large. In my particular field, I have plenty of patients because of the age range when you first join the military on average, who have their first psychotic break in basic training or as a result of military experience because they're under stress. So the idea is that if we know someone is at risk of developing full-blown schizophrenia, this diagnosis might be helpful to address stress management and perhaps discourage that person from choosing certain choices in life that might expose them to high levels of stress that could serve to be a trigger for the manifestation of those positive symptoms. People with attenuated psychosis syndrome are usually in some ways less severe than people who develop full-blown schizophrenia, at least early on. They tend to have good insight into their own symptoms and understand that something is wrong. So that's a little bit different than the average person who initially presents with schizophrenia. So onset and prevalence of schizophrenia worldwide is estimated between 0.2 and 1.5%. It is generally regarded that about 1% of the general population will develop schizophrenia. It very frequently develops in early adulthood. There is a common understanding that the first psychotic break will occur between the ages of about 17 and 21. Like that, those are really rough boundaries, but that is a very common presentation, is early adulthood. So many times this is when the person is just graduating high school, starting college, if that's their career path. Like I said, the military, basic training, emergences of transition in life where there's heavy stress, but it can emerge at any time. There are extremely rare cases of children, but they're not unheard of. The young man that I was working with when I was a psych tech, I believe he was 14 or 15, which would have been a little bit of an early onset. He also had a lot of other comorbid conditions going on. But generally speaking, we think of early adulthood as the most dangerous time for the development of schizophrenia. But as I said, many people will have already manifested negative and disorganized symptoms prior to having that psychotic break, and that can often be an early warning sign for people that may be prone to developing schizophrenia. So schizophrenia is generally regarded as a chronic condition, meaning that its course is ongoing. It does not resolve like an acute condition. Most people with schizophrenia experience moderate to severe lifetime impairment. This is one of the reasons why we refer to this as a serious mental illness, or it's captured under that umbrella of SMI, because the degree of impairment and often the degree of assistance and treatment intervention that these individuals require. Life expectancy for those with schizophrenia is slightly less than average. There is an increased risk for suicide. There's an increased risk for accidents, and that disorganization and lack of self-care can sometimes lead people to make poor choices regarding their health, and that can then lead them to have an increased mortality. As I'm sure many of you are painfully aware, much of the homeless population in various places is suffering from schizophrenia. That disorganization, that inability to connect with people socially or to ask for help, that sort of the eccentricity that can sometimes drive people away or make them uncomfortable, difficulty in organizing one's life, meeting responsibilities, all of these create a massive risk for homelessness. You'd couple that with deinstitutionalization that happened under Ronald Reagan. Nationwide, there was a massive push to reduce funding for inpatient psychiatric centers. Lots of state hospitals closed down in the 80s, and many of these people were basically pushed out of long-term psychiatric care out into the real world with no support network or limited resources, and ended up becoming homeless. So there is a large portion of people who have schizophrenia amongst homeless populations, more than in the general population, of course. As I've alluded to a little bit, there's something called the prodromal phase of schizophrenia. About 85% of those who eventually meet the diagnostic criteria will experience this, and it's usually 1 to 2 years before serious symptoms emerge. So the person is already displaying negative symptoms and disorganized symptoms. They may have impairment in functioning. They may show that apathy or avolition and have a lack of energy, be lethargic, no interest or initiative. They may be more isolative as a result, and they may be starting to have sort of like we might call psychosis light, like the very early stages. So ideas of reference, like this idea that someone is referring, everything does connect back to them, making those leaps of logic. Magical thinking, is a term for this idea of making illogical connections between how things are related to one another. The idea that if I don't think about getting sick, then I won't get sick is an example of magical thinking. Illusions, as I said, are not full-blown hallucinations, but they are distortions of existing stimuli into something else. And it can be auditory, it can be visual. But the idea is that the person is not creating sensory perceptions whole cloth out of nowhere, but they're taking existing stimulus and then turning it into something else. So there might be the sound of your radiator hissing very quietly, and you might start to interpret that as someone talking about you without actually hearing the details of the voice. I used the example earlier. You might have a hat rack or something in your home, or a coat rack that you in the dark you might misinterpret as being an individual in the room, that kind of thing. But the prodromal phase is really where we want to try and identify people at risk and start early intervention, and certainly kind of have people on your radar as far as looking out for the emergence of the first psychotic break, and making sure the person has the support system and the stress management skills maybe that can help them to negotiate that if it does happen. There are some slight differences typically associated, but what we found over time, especially with addressing some of our biases in diagnosis, is that it tends to affect males and females about equally, schizophrenia. Females tend to have a better long-term prognosis. The onset is sometimes slightly earlier for males, but in general it does not seem to discriminate across gender. Psychotic behaviors are not always pathologized, but we find that schizophrenia is similar in rate across all cultures. It really does. There's a reason why schizophrenia, even more than maybe any other psychological or psychiatric disorder, is regarded as having a biological cause. It seems to be something, even though, for example, people with schizophrenia are less likely to have biological children than people without it, it still maintains this like 1% prevalence in the population. So there's a strong belief that there's a massive biological underpinning for schizophrenia, and therefore it maintains a certain percentage of prevalence throughout cultures, across genders, and we'll talk a little bit in subsequent slides about causes. So this is an image from your book, which is sort of shows the longitudinal course of schizophrenia and starting with birth through old age. So the severity of the symptoms is shown on the left axis, and the changes in the symptoms are kind of detailed through each phase. So you talk about sort of gestation and birth. The person might have some very mild premorbid manifestations, mild motor, cognitive, social impairments, things that are not really standing out as being particularly abnormal, but maybe just below average. And then you get into this prodromal phase where the person starts to develop some of these unusual, disorganized, or negative symptoms. They may have these sort of psychotic-like behaviors like illusions or magical thinking or ideas of reference without being full-blown in terms of psychosis. Then you have this onset deterioration initial phase. This is when the psychotic break happens. The first positive mood symptoms emerge as well. And then you have sort of positive and negative and cognitive symptoms throughout the chronic or residual nature of the illness. So where do we think schizophrenia comes from? As I said, it is amongst all the disorders, it is probably the most believed to have a strong genetic or biological influence. There is an inherited tendency for schizophrenia in families, but not a specific form or manifestation. That's another reason why we got rid of the subtypes. The risk increases with genetic relatedness. So the more you share the DNA with an individual who has schizophrenia in your family, the more likely you are to develop it. So having a twin with schizophrenia incurs a greater risk than having an uncle or even a parent with schizophrenia. So it really is the degree of DNA you share with an individual seems to increase the risk for developing it. This is just a simple visual representation of that same idea. So monozygotic twins, you're approaching about a 50% concordance rate. Two parents who both have schizophrenia, their offspring are above 45%. Dizygotic twins, though, we've dropped down to below 20%. Sibling with one schizophrenic parent is now down to about 18%, and so on and so forth. As you get less and less connection genetically to an individual, further and further removed as far as how much shared DNA you have, the less your risk of developing schizophrenia. So this is a very good visual indicator of diminishing returns with diminishing connectedness in terms of DNA that makes a strong argument for a strong, albeit not 100% genetic component for schizophrenia. So as I said, twin studies are a good way to look at how DNA affects the development of disorders. We've talked about this throughout the class. So you're at greater risk for having an identical twin with schizophrenia versus dizygotic. So anytime we see that, we know, right, monozygotic twins share 100% of their DNA. Fraternal dizygotic twins, which are just like siblings in terms of DNA, share about 50% of their DNA. So this is that classic indicator of a genetic role being played in the etiology of a disease. One comment, I just caught myself saying that, so it's worth commenting on. I'm one of those people that thinks that the disease model is not always accurate or helpful when talking about abnormal psychology or mental health disorders. I prefer the term disorder to illness or disease. Working in the substance abuse field for many years, I also kind of had issues sometimes with the AA model of alcoholism as a disease, for example. I thought that was maybe not always the most useful way of thinking about it, and not necessarily even linguistically accurate when you look at how we define a disease or a pathology. That being said, because of the strong biological component and because of the pervasivity and the intensity of how schizophrenia affects people's functioning, I think we're more inclined, more commonly comfortable referring to it as an illness or a disease. Just to comment on the language, though, I think it's important that we always are mindful of how we're talking about these things. Adoptees are at risk for developing schizophrenia if a biological parent has schizophrenia, so no longer having a shared environment with the individual who has schizophrenia, but yet still seems to be a genetic component. Again, this is another indicator of a strong genetic cause for schizophrenia. The risk is lower than for children raised by their biological parents with schizophrenia. So We do know the environment plays a role. A healthy environment is a protective factor. This gets back to our ongoing discussion about diathesis stress. There is clearly, and the evidence would support the idea, there is a strong genetic diathesis for schizophrenia, but it requires a stressful enough environment to manifest those symptoms, and we don't ever know what that breaking point is going to be. As I mentioned, it's very common for it to happen when going away to college, joining the military, starting a new job, during a breakup, even during any kind of stressful event like moving. Things that cause people significant stress are often the triggers for that first psychotic break. And so by trying to minimize those stressors as much as one can in the environment, perhaps we're limiting the likelihood that schizophrenia will develop. But we're looking at the classic example, biopsychosocial influences. I mean, I'm sure you're sick of hearing it by now, and it is not a cop-out. I think it really is a reflection of our understanding of how these things work in the real world. But in the case of schizophrenia, there is a slightly stronger argument to be made for a genetic factor as at least putting you at increased risk for schizophrenia, coupled with environmental stressors. There's been a lot of research done because of the impairment, the degree of impairment amongst people with schizophrenia, because of the societal and personal cost that it takes from people. There's a lot of research on trying to understand it and trying to understand where it comes from. So linkage and association research looking at endophenotypes has shown that schizophrenia likely is polygenetic, that it involves multiple genes. And it's not caused by one single genetic indicator. Endophenotypes are basically the processes that contribute to the development or the maintenance of a disease. The behavioral markers have been found. There are a few, what's called smooth pursuit eye movement, which is just a biological indicator that can be measured. Schizophrenia patients show reduced ability to track a moving object with their eyes. This is just a correlation that is associated with schizophrenia. But we don't know exactly why that is, and we know that relatives of schizophrenic patients also show some milder deficits in this area as well. So there's something going on biologically that's connecting those two processes, but we're not sure why. So this is an example of correlation, not necessarily causality, but it is one indicator that's been found on a biological level. So what are the neurobiological influences? What's going on in the brain of an individual with schizophrenia that may be different than one without? The most supported and classic argument is what's called the dopamine hypothesis, that schizophrenia is partially caused by overactive dopamine. Now, this is really one of those situations where we reverse engineered our theory of etiology by virtue of the drugs that were developed. This happens quite a bit. So we see this with, for example, in depression with serotonin theories. You develop a drug like Prozac that is this SSRI, the selective serotonergic reuptake inhibitor, that essentially increases serotonin and depression gets better. So we work backwards in that logic to say, well, then perhaps depression is due to too little serotonin. When developing, I say we, I was not around, but when they developed the very first drugs like Thorazine that seemed to help with schizophrenia, they knew that those drugs were dopamine agonists. Dopamine antagonists, pardon me. So that they reduced the presence of dopamine at certain parts of the brain. So we know that drugs that increase dopamine agonists, like, for example, amphetamines, can result in schizophrenic-like behavior, right? So as we increase dopamine across various parts of the brain, you start to see psychosis. You start to see some of these symptoms manifesting. Also, certain drugs like hallucinogens that increase the amount of dopamine in the Raphe nuclei of the brain tend to cause auditory and visual hallucinations. So we're working with what the drugs do. We're seeing on a neurochemical level with these agents that are introduced to the brain, and then working backwards in our understanding of how that might be related to the underlying processes that cause these illnesses. So drugs that decrease dopamine antagonists, reduce schizophrenic-like behaviors. So, for example, if someone comes into the ER who has overdosed on methamphetamine and is experiencing a psychotic break, if you give them a drug that decreases dopamine, a dopamine antagonist, what's now called an antipsychotic medication, you will see the hallucinations start to go away. Right? So the drugs that have been developed for things like schizophrenia are typically called neuroleptics, antipsychotic medications, and they tend to decrease dopamine in certain parts of the brain. There is a drug called L-DOPA for Parkinson's disease, which is also utilized to treat a different dopaminergic system, but the unfortunate byproduct is that it can sometimes cause psychosis. So when we look at how all of these chemicals affect the brain, we get an understanding of what's going on in the absence of these chemicals to explain some of these illnesses. The problem with this theory is that it is likely overly simplistic, the same way that the pure serotonin model of depression is likely overly simplistic. There's more than likely more neurotransmitters than just dopamine involved, but there is plenty of evidence that dopamine does play a key role in the development of schizophrenia. There are some structural and functional abnormalities observed in the brains of individuals who have schizophrenia. Enlarged ventricles, these areas between the hemispheres of the brain, and reduced tissue volume, less density in the brain tissue. Less active frontal lobes, what's called hypofrontality. This is a major dopamine pathway in the frontal lobe of the brain. It's also part of our inhibitory and higher thinking abstract reasoning, the more civilizing aspects of the brain, if you will. And we know there's a lot of dopamine involved in that part of the brain, and people with schizophrenia show less activity under PET scan, SPECT scan, things like that. There's also some theory about viral infections during early prenatal development, but these findings are inconclusive. So looking for sort of a vector early in prenatal development that may be influencing the likelihood of developing schizophrenia, but mixed findings have not necessarily supported that at this time. This is a PET scan of an individual with schizophrenia who has never been medicated on the left. This is prior to medication. And then on the right, this person has received a medication called haloperidol, which is what's called an atypical antipsychotic. The red and yellow areas indicate the activity of what's called the D2 dopamine receptors. It's certain types of dopamine receptors in the brain. And haloperidol clearly reduces dopamine activity. And we know that haloperidol is also an effective antipsychotic medication. So this is how we utilize that back and forth iterative process to understand through drug use and through medications for these things, treatments, how we can understand the underlying processes as well. We know that marijuana use, especially in adolescents, can increase the risk for developing schizophrenia in at-risk individuals. So essentially, there is some evidence that early marijuana use can act as a stressor likely because of its mild hallucinogenic effects in some individuals, might be acting as the stressor to lead to the manifestation of the schizophrenia diathesis, the genetic predisposition to develop it. Basically, there's some limited evidence there, and we do know that, obviously, when it comes to marijuana use in general, most of the evidence about the significant harms of marijuana outside of smoking any substance and causing damage to the lung tissue is really about use in early stages of development, so adolescence, childhood, and even early adulthood. And this is just another example of how it can act as a trigger, perhaps, for people who are prone to developing schizophrenia regardless. There are some conclusions that are generally accepted about neurobiology and schizophrenia. We know that it is a diffuse neurobiological dysregulation, likely involving dopamine, but also likely involving other neurotransmitters, and that there are some structural and functional brain abnormalities that we are likely to observe in individuals who meet the criteria for schizophrenia. But this is not unique to schizophrenia. There are other illnesses, other mental illnesses, other diseases, disorders that also show differences in brain structure. But this is just one of the pathways of trying to understand it that have been explored. So what are the psychological and social influences that play a role in the development of schizophrenia? As I said, this is a diathesis stress example writ large. We know that stress plays a role in activating that underlying vulnerability. So stress also increases the risk of relapse, meaning the reemergence of psychotic symptoms or more problematic negative or catatonic symptoms, disorganized symptoms, excuse me. So people who have schizophrenia, who meet the diagnostic criteria, likely will undergo some significant stressor. That first manifestation, the first psychotic break will happen, and then as life goes on, as that person is put under stress, even if perhaps they're taking medication, they're more at risk to develop a relapse to more active symptoms. There are some unsupported theories about family interaction, and I think it's important to take a moment and talk about some of these. Many of these have been disproven, and are unsupported, and it's a good thing that they are, because I think for a long time they were sort of utilized to unfairly blame parents, specifically mothers. There was this thing called the I can't even say it, schizophrenogenic mother. So the idea that there was some initial research that found a correlation between people with schizophrenia and having cold and dominant mother figures in their life. This has not been substantiated, and it caused a lot of guilt and a lot of shame in parents whose children develop psychotic disorders, a lot of second guessing yourself, and I think it's really important that we make it clear to people this is not supported by the evidence, if only to remove that sense of guilt and shame. There is some research into this idea of double-bind communication, parenting styles that involve a lot of mixed messages. So, being given counter instructions so you don't know what to do, or being told that you have to sort of be of two minds about things in order to understand it. So being told that, seeing no way out, no correct answer to a question or to a directive from a parent. Again, also not substantiated and not linked in the empirical research to schizophrenia. There is something called high expressed emotion, which has been theoretically associated with schizophrenia. What we've now found, this is like criticism, hostility, over-involvement, intrusiveness. This is like that, that unfortunate stereotype of the cold and dominant mother. But we do know that high expressed emotion, so sort of really intense expressions of anger, fear, anxiety, that kind of thing, hostility, being very critical, these are associated with relapse. So this is just simply an example of environmental stress that's making it possible for the person to go through a reemergence of some of the more problematic symptoms. So psychological factors may function as the diathesis in a diathesis stress model as well, but we know that mostly when we talk about the diathesis, we're talking about genetics. So they tend to exert only a minimal effect in producing schizophrenia, but they certainly seem to play a role, at least from a correlational perspective, in the emergence of schizophrenia and perhaps in the relapse of a person who already has it. The historical precursors and treatment for schizophrenia it's a long list, and it's pretty barbaric, including some forms of things we would now consider torture. But unfortunately, as we look at the history of abnormal psychology, this has been the case for all kinds of disorders, not just schizophrenia. Schizophrenia happens to be one of the more patently manifest representations of mental illness or of mental disorders, and therefore it's been the recipient of a lot of unfortunate attempts to treat it, and many of which, like I said, are very cruel. Neuroleptic medications, antipsychotic medications, as these are often called, were developed starting in the 1950s, and these became the first-line treatment for schizophrenia. What I like to say about these medications is they started off as blunt instruments, and they have become more like a scalpel as time has gone on. Now, they are not perfect by any means, and we don't have a magic bullet that cures schizophrenia, all the symptoms. But these medications were particularly helpful in treating the positive symptoms, in reducing the intensity or the presence of hallucinations and delusions, and they remain so. Those first medications you might know under the name Thorazine is the most common one. More modern antipsychotic medications include things they call the atypical antipsychotics. They're called atypical because they don't just affect dopamine, they also affect serotonin and glutamate systems. These might be things like risperidone or haloperidol are more common. But what they do is they really reduce or eliminate the positive symptoms. We use these same medications in other settings to treat psychosis and agitation. Limited efficacy, but in dementias, we often use atypical antipsychotics. They're used at the end of life for agitation and restlessness. And they're certainly used to sort of stabilize people in the ER who are having some kind of psychotic reaction to substances, for example, or an infection. Some of those more historical precursors include things like insulin coma induction, psychosurgery like lobotomies, and very damaging degrees and levels of electroconvulsive shock therapy. So none of these were very effective at treating schizophrenia before the emergence of these drugs. And like I said, we've seen the drugs develop and become better over time with less side effects. They have some significant negative costs that we'll talk about in the next slide. So there are some acute and permanent side effects that are common with first generation medications. Because we've talked about how dopamine is involved in other types of disorders, you can start to understand how, unfortunately, if, let me simplify this overly so. If schizophrenia is involved in an abundance of dopamine in certain parts of the brain, in those D2 receptors, we also know that in another part of the brain called the nigrostriatal complex, Parkinson's disease is associated with not enough dopamine. So this is a sort of opposite proposed theories about what's causing these conditions. One of the reasons we make that connection and we understand Parkinson's and schizophrenia better in relation to one another is because these early medications caused Parkinsonian side effects. The people would develop tremors, things that we associate, or even freezing, different types of motor disorder that we associate with Parkinson's disease. There's a set of symptoms called tardive dyskinesia. If you break that down a little bit, dyskinesia is like, is maladaptive movement of some type. Basically, these are involuntary movements of the face, the hands, the mouth, etc. For example, involuntary protrusion of the tongue, so pushing the tongue constantly into the gum or out of the mouth, anything like that, is something you might see somebody doing over and over in a repetitive fashion, who's taken a lot of these first generation, second generation antipsychotics, and it becomes involuntary. It's not something that you can stop. People can do things with they do what's called pill rolling, which is rolling, I can't see me in the camera here, rolling your finger like this is a common tardive dyskinesia symptom. So these are some very serious negative side effects that are associated with schizophrenia. And compliance with medication becomes a problem, and it's gotten better with the medications getting better, but it's very difficult to get someone to consistently take a medication that allows them to function better and minimizes their symptoms because the side effects are aversive. Early on, these medications were also quite expensive, and you're talking about people that often have difficulty with financial instability or security. And then it also leads to poor relationships with doctors, difficulty trusting, difficulty communicating. One thing we've seen in the development of these drugs over time is different systems of delivery that are less prone to compliance problems. So taking a pill every day requires a certain buy-in, a certain responsibility, a certain organization in your thinking, in your behavior, that some people may struggle with. But there are injectable versions of these antipsychotics, some of which can last for as long as 6 months. So these are like sort of slow release injectables. And this has become one way of trying to increase compliance with schizophrenia. So you have the person come in for one visit, get this injection, and the medication is at a steady state in their body for the most part for several months. And then really it's just getting them to come back for that follow-up appointment as opposed to taking a pill every single day. Psychodynamic therapy, the early days of psychology was not found to be very effective at all with schizophrenia. Traditional therapy, as far as sort of a talking cure or the idea of working through, in traditional cognitive behavioral therapy, we look at sort of irrational belief systems and irrational assumptions about the world and yourself. Those types of therapies are generally not terribly effective for schizophrenia, but there are what are called some psychosocial approaches that seem to work. Many of them are very concrete and behavioral, so things like token economies on inpatient units, rewarding adaptive behavior, so self-care, good hygiene, taking medication, complying with treatment programs, that kind of thing. So just trying to utilize simple operant conditioning can be helpful. Community care programs that provide a built-in social safety net for that individual and connection with people that are going to check in regularly with them and help them to organize their lives a little better can be very effective. Social and living skills training, this is trying to address some of those negative and disorganized symptoms, helping people how to more accurately understand people's nonverbal communication, how to sort of work on developing healthier social skills like appropriate affect, eye contact, trying to minimize eccentric speech that makes it difficult to communicate, that kind of thing. There's plenty of work that can be done working with families and helping them to assist the individual who's dealing with schizophrenia, and then vocational rehab. So finding opportunities for people with schizophrenia to be productive and to be effective in certain types of jobs, and to sort of get them back to a place of more organized behavior and more consistent, reliable engagement with society. There is also a lot of emphasis in recent years with serious mental illness, especially schizophrenia, with the idea of recovery, trying to get away from the idea this is always going to be managed, giving people more of a positivistic viewpoint that there's potential for a lot of gains, a lot of improvement. So you want to engage the patient as an active participant in their care. They are collaborating with their treatment care team and feeling empowered and a sense of agency in their treatment. You work on goal setting and tracking those goals continuously and really helping the person to get some concrete reminders and sort of motivation from what's going on day to day. And this often will be done in sort of a module form. At the VA where I work, they have a program called the Psychosocial Recovery and Rehabilitation Center, the PRRC, and they've actually developed what they call a semester system where they treat it almost like you would a community college, where the people can sign up for various classes each semester, and those classes are focused on things like social skills training, managing stress, socialization, substance use, all these things that sometimes go hand in hand with schizophrenia. So helping people to, manage interpersonal relationships, that kind of thing. But the individual gets to choose what they want to focus on. And I think it is a very empowering program that involves a lot of agency on the part of people that are often regarded, unfortunately, by society as largely incompetent, as not capable, and requiring a lot of oversight and a lot of paternalistic oversight of people deciding what's best for that individual. So modern approaches to treatment are trying to bring some agency back into the ideas of how we deal with schizophrenia and helping people to feel like they're more active and actively involved in their care. This has been shown to increase a lot of positive outcomes, including engagement with medical management of your condition. People who have these sorts of more comprehensive programs are much more likely to show up and take their medication on a daily basis or come get their injection from psychiatry. So keeping them involved and engaged with care and not falling through the cracks, which is very common with people with schizophrenia because of their disorganization, because of them often being sort of stigmatized and pushed to the edges of society, trying to help people have some safety nets to keep that from happening. So we need to keep in mind a lot of cultural considerations with schizophrenia, because if you think about it, many of the symptoms we associate with schizophrenia out of context, taken back 100, 200, 1,000 years, are going to be regarded very differently. So supernatural belief systems, for example, hearing voices in the modern era means one thing. Hearing voices in other types of cultures, even in the modern era, or going back in the past, might mean demonic possession, or a person who is connected to spirits from the past, or ghosts, or whatever you want to call it. So you need to understand the person's culture and their understanding of what it means to have these symptoms, rather than just, this very straightforward, everything is logical and medical and that's all there is to it. So we need to consider culture when we're treating schizophrenia. We also need to try and involve the family and the community as a social support network whenever that's possible, because it's associated with much better outcomes. One thing we can do is to try and identify people who are at risk in childhood for developing it. Now, of course, we know if the more shared genetics that you have, the more at risk you are. So relatives of individuals with schizophrenia might be sort of your first line identification of at-risk people. But you look for individuals that are starting to manifest those sort of early negative and disorganized symptoms, who might be entering that prodromal phase. So offering more treatment, including things that are very concrete, like social skills training, stress management, getting the person engaged with treatment maybe before they've even developed what we might call schizophrenia under the modern syndrome. You also want to foster as many supportive and stable environments, because you're reducing the stress and therefore minimizing the manifestation of that diathesis, that genetic weakness to develop schizophrenia. So there are some really interesting programs that are done with at-risk individuals to try and prevent the development of full-blown schizophrenia, and when it does develop, to have a better system in place to assist that individual in being more productive and more engaged in their life. This is just some examples from research of a treatment from 1980 to 1992. So people were assigned to one of three groups. In all three groups, they were receiving antipsychotic medication. And what they found was that support or education showed some decrease in major relapse, but that social skills training and family stress management seemed to be more effective by a pretty significant amount. Here you can see by about 20-25% in reducing the likelihood of relapse after 2 years of initial diagnosis. So we do know that these psychosocial interventions make a difference in the course of the illness for that individual. So how do we summarize these disorders? There's a reason why these disorders have their own chapter in the DSM. I think their characteristics are somewhat unique. They are distinct from some of the other disorders we've talked about thus far, while there are a few symptoms that overlap. But essentially what we're looking at is not just the psychosis, not just the break from reality, but really how that break from reality can result in a spectrum of dysfunction. So it's not just hallucinations and delusions that make schizophrenia. The cognitive, emotional, behavioral domains are all really important and may even be bigger contributors to that person's difficulty functioning and their distress than even the things we might think of as distressing, like hallucinations. It does involve this triad of positive, negative, and disorganized symptoms in terms of the schizophrenia diagnosis. And amongst the other psychotic disorders, we see one or more of these same symptoms manifesting, sometimes just one symptom in isolation, things like delusional disorder or catatonia. We know that medication is somewhat effective for managing the positive symptoms, but there is much room for improvement in these medications. They do target largely just the positive symptoms and don't do a lot for the negative and disorganized symptoms. There are no real drugs that are out there that seem to have a significant impact on that. So this idea of a more integrated treatment that involves not just medication, but other psychosocial interventions that are targeting the negative and disorganized symptoms is especially helpful and can increase the person's functioning and decrease distress.